We move to our next session themed Point of Care Test and Technology in Remote Healthcare Setups and its Role. The title of this talk is Relevant Specialist Care in Secondary Hospital Settings in Oddanchatram. We would like to invite our speaker, Dr. Cijoy Kuriakose, for the same. We invite Dr. Vijayanand Ismail to moderate this session.
It's my pleasure to introduce Dr. Cijoy Kuriakose. He did his MBBS from Calicut Medical College, his Diploma National Board from Christian Fellowship Hospital, Oddanchatram, and postdoctoral fellowship in endocrinology from CMC Vellore. He has been associated with the Christian Fellowship Hospital, Oddanchatram from 2000. And he has about 20 articles published in various journals. He's also a motivational speaker and motivated a lot of people to consider a life of service. He's going to talk about experience at the Christian Fellowship Hospital. And this hospital has been a great blessing to motivate people to go to remote places in India, including myself. So I was there shortly after my MBBS for 3 years from 87 to 90. So I invite Dr. Kuriakose to speak on this topic.
Thank you, sir. Good morning. What I'm supposed to share is the experience of our center, which is probably a long story, around 69 years story, but I have been part of this journey only in the last 20 or so years. But this has been there before even our joining. So I'll be mainly focusing on the current situation that we are facing, mainly in the theme of equity that we are looking at. What is the relevance of specialist care in secondary hospital settings? So I would like to look at it in three different aspects. One is the legacy of the institution, the strategies that we employed, and the complexities and the challenges with regard to specialist care. This lady has been sort of the poster lady of our hospital's history. Most of us do not know her name, but she has been one of the recipients of very good care in the initial days. And I'm told that she was even partly a health worker, a trained health worker in the later years. A hospital was started in 1955. The founders of the hospital moved into this place called Oddanchatram, which is situated between Coimbatore and Madurai, two big cities, both around 100 plus kilometers on either side, north and south. They chose this place because as a group of individuals, when they were students in the Miraj Medical School in Maharashtra, they were prompted this was the time of immediately after the Indian independence, and they were prompted to look at places where there are very less medical facilities available and to move in there. So they found this place. Two teams were there. One team moved to Rajnandgaon in North India, and the other team found that Oddanchatram in South lacked enough healthcare facilities. In 80-kilometer diameter, there was not even one medical doctor available. So they chose this place, and in the initial years of their stay in that place, they had a lot of challenges. This is the house called the haunted house, because this was available free of rent for them initially, because there was no good houses in those localities those days. But because this was supposedly haunted, they got it free of cost. And this was the place where the first C-section was done, because a lady happened to come in obstructed labor and was refusing to take the patient to a higher center. And they didn't have a theater, not even a proper OPD. They just boiled the instruments in their usual kitchen utensils and operated on the lady in their dining hall. And that was the beginning of the journey. And it was a miracle lady and a miracle baby for the locality, because that was the first time anybody is being delivered directly from the abdomen in that locality. And many people came to see the miracle, the mother and the child, and that started. So this is the legacy of being able to do much more than what is available. for a haunted house with no medical facilities to do a C-section was way beyond its scope and capacity. And that is the legacy that we started with. Even those days, our founders were fairly overqualified for the work that they were doing. Even in that era, they kept qualifying themselves, training themselves in various places, in various specialities, the same person going and doing various specialities and coming back, because they felt in their heart it is, even though we are serving the poor, and that care should not be substandard care, to the point that after a few years, many decades back, even closed mitral valvotomy was done in secondary care hospital with the help of a visiting cardiothoracic surgeon. Their principle was this, that the primary care doesn't mean preventive care, secondary care is not second-rate care, and low-cost care doesn't mean low-quality care. This was the principle that pushed them to equip themselves and train themselves to give the best possible to people. But coming the middle years, they realized that it was not just sufficient for us to remain in the hospital and do this, because many patients were not willing to come to the hospital. So they realized that there is a need. If you need to transform the communities, you need to move into the communities, and that's how community care came into being. In the subsequent years, it was the backbone of the hospital's development, and outreach work was the family medicine. And it was with a lot of gratitude that we can remember a lot of the pioneers of the family medicine movement in India were trained and were products from the institution and related institutions. So they, from in the founders onwards, they had this principle with which they worked, from everyone according to their ability and to everyone according to their need, because it was a self-sustaining model without any external supports, to exclusively depend on the income coming from the patients. And to support that sort of a subsidized care, they had to depend on this sort of a principle of equity. I still remember in the early 2000s, we even had someone coming from CMC Vellore, cardiologist coming from CMC Vellore, because a lot of our patients those days were waiting for a mitral valve valvotomy, PTMC as we know now, the balloon mitral valvotomy, those days we used to call. Many were waiting and they were not willing to go anywhere else. And there was a person who was willing to just come over there. And among the low-risk people, among those mitral stenosis patients, they underwent a balloon mitral valvotomy under a C-arm, which was used by the orthopedic department without any cath lab. So that was possible. So it was again an example of how you could do more than the scope of that place. The current years, there is a changing context. We have been listening to that. There are many private hospitals which have come into the place in that small town itself. Now we have 2 hospitals exclusively for orthopedic procedures. We have a hospital with at least 1 dialysis machine available. The government hospital, you can see the big arch down in the picture down. Fairly good facilities and very good transportation facilities in our part of Tamil Nadu. So transporting patients to the medical hubs of Coimbatore and Madurai are not very difficult, and therefore the expectations also change. This is the context that we have come into right now. And when we came into this, how do we strategize? How do we change? This is the next question that we had to ask. So even among our patients, we found that the context was changing. The characteristics of the patients were changing. We were seeing more and more of complex problems. Our logicians are saying they are not seeing any more normal deliveries, because normal deliveries are done in many other centers. The complex ones, the complicated ones are the ones who are coming to us. The most patients come to us partially treated. It is usually the second or third stop for care for 2-3 districts of patients coming from 2-3 districts in that area, not because of lack of medical facilities. There are lots of medical facilities, but we found that the patients who access our care needed much more inputs into their medical care. And of course, in the tertiary centers, the spiraling costs of care was a prohibitive factor for people. So we had to ask these questions to ourselves. How do we remain relevant, at the same time holding on to the original ethos of the place? How do we embrace change, holding on to the orthodox values? As younger people, I also used to think orthodox meant wrong. but interestingly, the dictionary doesn't give that meaning. But so we had to ask this question: how do we change very productively while holding on to these values? So we had three major things to look at. One, how to decide which area to focus on. First was to keep track on the changes in the disease burden in our patient group. Of course, the global burden of diseases help us, but always having an eye on what is happening in our locality. There was definitely a shift from communicable diseases to non-communicable diseases, but it was not at the cost of neglecting our traditional strong points like infectious diseases, tuberculosis, and HIV, and others. It was always a thought of specialty care, not at the cost of primary care, but for the benefit of primary care. That was the principle on which it was initiated. So first question, what are the changes in the disease burden that we are seeing? The second question was, what are the gaps in the available care? That is our relevance. There was a need for an ICU because of the complexity of the problems. There was a need for cath lab and dialysis. How did we say that there was a need for a cath lab and not for a bone marrow transplant unit, for example? Because both are requiring quite high specialty care. One of the ways we assessed that was to look at the numbers of patients that we were referring. There was a time every day one ambulance will be standing there to take a patient with an MI who was thrombolized and who wanted to go for a angioplasty or something because of the availability of the CM insurance scheme and all. So this was happening. So we had the numbers there telling us that there is a need in the community. And also we had very good feedback from our own community of well-wishers whom we meet with informally and formally at least once a year, where the community leaders tell us what they would want us to do. So this is one request which has kept on coming back again. Can you start a cath lab? Can you start a cath lab? We don't want to go to Coimbatore or Madurai for acute coronary events. So this was a request. A gap was there, a need was there, and that was a second question. Thirdly, need and gap is not sufficient. We need to have the people to take up this. It is a divine provision of people, I believe, that there were people who were having interest and the willingness, especially when it came to the medical specialties that we found. For many surgical subspecialties, we have people on visiting basis, and they come and help us when we keep the patients on an elective basis. Of course, emergencies, very few of them can be done on a visiting basis, but elective basis, quite a lot of those can be done. And that is a third thing. So three important aspects of how to improve upon the care was on looking at what are the changes, finding that. Second, what are the gaps? Changes may be there, but there may be people who are providing for those changes. Then we don't have to duplicate that. What are the gaps that are available? And do we have the provision of people? Of course, the resources will come. So this, looking back at this, I feel this whole concept of calling has come into place. It is the novelist and author Fred Buechner who said that the place God calls you is the place where your deep gladness and the world's deep hunger meet. So this is what we have found in our experience, where there is a deep need and there are people who are really desirous of meeting that need. When those two met, that was called the vocation or calling. So that is, we found the current scenario. We have a fairly good amount of specialties, both medical and surgical. And many of the other general specialties like ENT and ophthalmology also have upgraded their services in the past few years. Along with that, we have been strengthening home care, palliative care, even home collection of blood and for laboratory services, because that was one of the main complaints that came from our patients, that when you come to your hospital, it takes a whole day. You are giving blood in the morning, then only by evening, everything is over. So even that option of going and collecting blood in their homes for the people from our locality also has started. The original haunted house that I showed you is still there, and it has been recently renovated into a citizens clinic or a town clinic, which is to start functioning soon. I just want to mention a little bit about the medical subspecialties, because that is the focus group here. We moved into installing a cath lab with much trepidation because of the huge cost of involved in that. Almost a large chunk of all the reserves that we had to be pumped into this, because it was a high investment thing. And we knew when we did that also, the capital expenditure probably is not going to be recovered, but we could, by the CM scheme, the insurance scheme, we could at least recover the expenses on the consumables. And there are, of course, there are a lot of collateral benefits of patients who are able to access care, not only for cardiac services, but because the cardiac service is available, the people are able to access care for the other things. For example, a patient who was having CKD, going from hospital to hospital, nobody is willing to do a cataract surgery, was able to do cataract surgery because of the backup of the dialysis facility here. Similarly, somebody with a small problem like a hernia or a hydrocele itself, some getting rejected because of the lack of services. So these are some of the collateral benefits that we've found. But when we strongly rely on the government's insurance schemes where the returns are very low, we are just able to manage the consumables, and we can break even only for those, but not for the huge capital expenditure. Of course, the low salaries helped. Total expenditure on salaries of the staff come to around 42%. That too has been a recent jump only. It was almost always less than 30, as opposed to mostly around 70% in most medical facilities, especially in the private sector. So this has helped. Of course, there has been a lot of support from institutions like CMC with the cardiology, even with the negotiations with the companies for the cath lab, and through institutions and organizations were willing to handhold us and take us through. We very gratefully remember those interventions. In nephrology also, we had the Rotary Club coming in and being willing to give us any number of dialysis. After initial investment of dialysis machines, they are now willing to give us many more, but we don't have any space to keep them. So they are saying, if you want dialysis machines, we are willing to provide you dialysis machines. Almost all chronic dialysis, close to 100% of our chronic dialysis patients are under this insurance scheme from the government, which means it is 100% free for them. And here also, it's only about breaking even for consumables. And we have become the highest number of dialysis being done in the district is in our hospital now. Even though we are not in the district headquarters, we are in only one of the small towns in the district. We belong to the Dindigul district of Tamil Nadu. Of course, insurance brings with it all the documentation burden and all those difficult issues, but because it has been a teamwork of so many people putting their efforts together to do this in case of insurance schemes. Gastroenterology has also received a big improvement these days with our gastroenterologists joining us, with significant increase in upper and lower GI scopies, with initiation of endotherapy, polypectomies, and emergency management. That has been a very important thing for people, bleeders who come with hematemesis, who had been treated with hemoclips and banding, and even foreign body removals. Of course, the technicians and nurses were given quite a lot of training from CMC. That was very helpful. We have also started a neurophysiology lab. One of our senior physicians were willing to go and train himself in Ludhiana, and Dr. Jairaj Pandyan was mentioning yesterday, in stroke care and epilepsy care, and also having regular visits from a senior neurology consultant. Pulmonology also, daily outpatient clinic has been started, and an outsourced facility for sleep study is being planned, and bronchoscopy is also going to be started soon. Another aspect is that in a secondary hospital, you cannot manage everything. Even if you invest in some of the subspecialties, it will be quite difficult to manage many of them. So that is where we use this diagnose, refer, and follow-up model. I would like to bring the story of this 26-year-old lady, IT professional. During the COVID time, most of those who were working from our locality, who were origins in our locality, but were working in Bangalore and Chennai, they came back home and then were working from home. And she presented to us with recent onset weight gain and hypertension and diabetes and menstrual irregularity, and subsequently was diagnosed with pituitary onset Cushing's disease. But this is something that we can only diagnose. We couldn't manage the neurosurgical part of the next step of her management. So she had to be referred to a tertiary center in Pondicherry, and from where she had been referred to another tertiary center in Mumbai, and where she underwent her pituitary adenoma resection. And she's been on follow-up. After that, she came back and has been on follow-up and is doing very well. So this is something that we have to be content with in a secondary care. We cannot manage everything. There are certain things we may be able to manage, certain things we may have to find. Even that diagnosing itself is a help for the patients. Refer them if they are willing to come back, because we are closer to them, continue their follow-up care. So what has helped so far? One, there was the need for these services. Two, there was the availability and willingness of personnel from within and from outside to help. And there was a hard work of various teams involved in infrastructure development, insurance, and collaboration, etc. There was also this generous help from various organizations, institutions in bringing skilled people. A lot of supports we have received. So we have this flexible model on one side of preventive care and to the other extent of therapeutic care, with a lot of flexibility, where the community physicians move into look at home care and even family medicine. Family physicians do a lot of internal medicine and do a lot of internist work in hospital care, where the subspecialty doctors also do a lot of internal medicine work, do medicine rounds, and even take duties in medicine. So a lot of in the spectrum, there has been a lot of movement, which is very unusual in the current day scenario outside. I do not know how long this will last, but this is how it is right now. It's heavily subsidized on one side, the other side subsidized with some amount of cross-subsidy. This flexibility has really helped us to have some maneuverability about personnel. Finally, what are the difficulties? What are the challenges, the complexities that we have faced? I would put it in three different headings. One is the personnel, which is the most important probably, and then financial and infrastructural. I would say in any equitable care that you want to give, this will be probably, in my personal opinion, I would think this is the most crucial. This is the rate limiting step in the whole process. People willing to come, willing to be available, willing to break the me barrier, the so-called me barrier, and be able to be available to serve the underserved populations. We see very similar patterns around the world. There has been this study from about medical school graduates in US in 2018. Who had the greater odds of reporting intention to work with undeserved populations. Only reporting, not really working, but who all had a desire to work among the poorly represented people, women, underrepresented minorities, people who had a lot of loans, people who intended to practice primary care and who emphasized on non-clinical careers. So basically, main non-stream players were the people who were willing to move out generally. Last month, JAMA had published this about a question that was asked to US medical students. Do you plan to work primarily in an underserved area? Higher odds were found with females and minority physicians. Again, a non-mainstream individual. I do not know how this translates to India, but this is what they've been found. Probably it is a minority who would prefer to work in underserved populations, and they are generally not mainstream. You can call them a little off. So those are the people who are really available for working in underserved localities. There is this interesting article on corporatization of healthcare from Maharashtra in India, BMJ Global Health. It came up. So one thing that they have noticed is the star doctor, super doctor concept that is coming up in India, where a new professional elite that is a hybrid of a medical practitioner with a businessman and a celebrity philanthropist, that is very strongly put up in the Indian media as well as in the public space. This changes the employment relationships and using of performance targets, and all those things have actually affected equitable healthcare. So there is this kind of a new role model which has developed for medical students. This is the type of doctor I would like to become. This is the type of star doctor or a super doctor that I would like to become. And other role models are very, very, very less in our space now. I'm very thankful for this conference. If not for anything else, all the information that has been pumped in, at least it will be an avenue for people, younger people, to see that alternatives exist. And here we have a focus, unusual focus of people who have done these, a different role model, not the role model that this paper showed. There is the other model that is seen in the West also, which is very relevant in our settings also. In Massachusetts, it's a city with a lot of medical professionals, very famous city for medicine and technology and all. What made people, specialists, move into underserved areas? One, the primary motivation was that they didn't have enough patients in the city. They had to go out into the suburban places for their professional needs and for income. But interestingly, after they moved out, they continued. Many of them continued, and their secondary motivations for continuation was not primarily income or their professional need, but that was more altruistic in nature, and they felt the obligation to the needs of the patients, the rural community. The community also challenged them. So this is what they have found. There is this paper brought out by the Public Health Foundation of India from 2010 in Chhattisgarh. What are the major factors for doctors to serve in rural areas? Of course, there are local factors like ethnic and tribal affinities, geographical things and all. But some of the other things that they noticed were the personal values that they held, the strong relationships with their colleagues, and the anticipation of security or of regular job and all. What have we seen? What retains people personal in this thing was, one, mostly importantly, we found that it was personal values. They felt called. They felt that this is what they are supposed to do. Secondly, there was a community which will have their backs on. And there were always family. One of the reasons where people left was that their spouses or their children did not have enough opportunities in the place. Another one, we very gladly happy that professional exposure, the variety of patients and the type of satisfaction that you get from dealing with their problems and being able to involve in them. The second complex issue is about financial. This is what is called as the iron triangle of healthcare, or the triple constraint. William Kissick brought it up, where quality, cost, and time. How in medical care, in healthcare, very often these three cannot be maneuvered. When you adjust one thing, the other two also get affected. You can have good, fast, and cheap, but only two of them at a time. If it is good and fast, it cannot be cheap. If it is fast and cheap, it cannot be good. If it is good and cheap, it cannot be fast. Of course, there are very many ways in which people are trying to improve upon this, but this is a very real struggle for us. When you try on improving one side of the triangle, something gets affected in the other sides. How do we keep our services affordable and sustainable? One of the models for the old mission hospitals was high volume that makes up for the low margins, but that is probably changing. One of the important things that we did was to have patient-centric negotiations with pharma and with outsourced services, refusing all freebies, all kickbacks, all pharma-sponsored programs, so that everything that the pharma is willing to give will ultimately go into the patient's care. They will reduce all those on the price of the medications that they are providing us. So this is one thing that we could look at. We have a heavy reliance on government insurance. It may not be very healthy from a management perspective. And defining quality also, we have to define quality in a very dynamic way, a population-specific manner. This is also very important. I had a very brief stint 20 years back when my wife was doing her post-graduation in Trivandrum. I briefly worked in a corporate, the top hospital in that area. And the MD, during my interview process, he was just telling me, we are not running a hospital, we are running a hotel with medical facilities. So that was very clear in his mind what his bottom line was. That is defined as quality. You had every day fresh flowers in your room, and the bedsheet being changed every few hours. All these, the hospital menu available in the dietary, having all sorts of cuisines. All these things are considered quality in one setup. But in our local setup, we have to look at and define quality for our community and specific for that. Finally, infrastructural. I feel that when personnel is there, financial and infrastructural are not very important. It will just come. It is the personnel who, in my personal opinion, That is most important. We have had a lot of more partnerships than the pre-COVID times. After the COVID, with many philanthropists, the CSR funds from many organizations like Rotary, some of the services which we found that we cannot afford MRI, but thankfully there was somebody who was willing to come and put up an MRI, but we just needed to provide the space and the building. How can training institutions help? Sometimes training beyond the classical. Very often when you are trained in your MD program or MS program or DMD, MCH programs, you're not, technical support is taken for granted. I have worked with our nephrologists during the process of setting up a dialysis unit. The greatest struggle they had was how to make this RO water sterile. Not about a big problem with a machine, just the problem of a water. So he was telling, nobody told me that when I trained to be a nephrologist, nobody told me that this is going to be a problem. So can training institutions simulate certain situations that they may end up facing in resource limited situations? A cath lab or a dialysis unit or for that matter, any other, even an ICU, what are the things that you may have to manage? Personal management, absolutely no training in our post-graduation, but that is what you are rightly pushed into. The moment you reach a place, you are given a unit for yourself and you're asked to, there is nobody else, you have to take over. And I remember as an intern, when we were posted in the government setup, as an intern, we were supposed to manage the people who are 30, 40 years senior to us, the health workers and people. They had a lot more of experience, but absolutely no inputs into our training in personal management. Of course, other supports can also be given by training institutions. Tactical support, as I mentioned, about which machine to get, what would be ideal for our sort of setup. These sort of things can also be helped. So how what have we learned? One, there is a rich legacy of health equity conscious health provisions and strategies which have to be evolved in an equitable manner, and challenges in terms of men, money, and material. Ours is not a success story. I do not know how long this will go on like this. We do not know. As of now, this is going on, but this is a story of very humble attempts, real struggles, and helpless dependence on God. Not the question is not whether we have really broken even financially. We had the return of investment, but whether we have made a difference. We may fail according to various parameters. A management personnel would probably tell our success parameters are wavered, but we really hope that we would stand the test of faithfulness, where we would consider that being faithful to what has been given to us, being good stewards of what has been given to us, would be considered as successfulness. It is, I think, the Coast Guard which had this logo which said, you have to go out, but you don't have to come back. It is not the returns that was very important, the impact that is not very important, but given the resources, given the situation, have I been able to do what I am supposed to do? You have to go out. You don't necessarily have to come back. So thank you for this time.
So brilliant to hear the entire journey of ODC and also as a person who I might call myself as a slightly overqualified person who went to similar areas as you. I have two questions, and in fact, starting with comments on this, that your presentation brought out as issues, not as what you've done. First is, you really brought out that there is a need for appropriate tertiary care of the people who are poor, which needs to be also taken into cognizance and be delivered closer to where people stay, rather than ensure that you have a hub and spoke model, and where the spokes, I don't know how long they would be, but what you're trying to say, that we need to get even appropriate tertiary care closer to people. And I think it's a no-brainer, and I think that, but it has to be said, and you said it so beautifully. But my second comment is comes along with a question. What you try to show, and your experience, that we need units, we need domain specialists for problems more and more in primary care, at primary level, or maybe at secondary level, where I have a fundamental concern that, are we trying to eulogize, the power of specialized care, domain specialized care, rather than a multi-trained? I don't call family physician as a generalist. He's a specialized generalist, in that sense. And whether, I would rather suggest there's a possibility can we make 20 specialties be trained into a single specialized generalist, as I may say, rather than have 20 specialists, finding their way in a system, and creating their own cath labs and their own renal replacement units. So whether it's the person who can do this, and so can we not write books like where there is no neurologist, where there's no nephrologist, rather than you push in cardiologists with their cath labs and their nephrologists with their dialysis units into primary level care. And I have a healthy suspicion and a dislike for domain specialists, because they are often more expensive, they're less available, and they're less socially conscious about equity issues and about problems of their own specialty also often. And technically, sometimes they make not so good decisions as generalists do. So I'm just throwing being a devil's advocate for saying, speaking up for the family physicians, and ODC as a classical example of a nursery for family physicians. Are you not sort of stepping on the toes of the wonderful family physician that you've had by advocating for specialists taking on these roles in your place? Thank you.
Thank you, sir. I'm sure you have more ideas because you've been doing that yourself. Have given your training and all, how overqualified you were when you moved into the place. So that's what I was trying to explain in one of those graphs, where this flexibility of the spectrum, where a family physician is also able to develop as an internist. An internist is able to do what a family physician does. A specialist who has been trained exclusively in one of the specialities, able to handle the specialities that he is not able to handle. That is the model that has worked for us, but I'm not sure it will work everywhere. But for us, it has been like, I'm personally very grateful for that model, because even after having trained in endocrinology, I have a lot of freedom. I am so happy that I am able to manage more medicine than endocrine. So that sort of a division in my own personal workspace, I feel is unique. Not all places give you that freedom. So that flexibility actually helps us in giving that side and this side together. I hope it will continue like that. But I don't know, sir. If you ask me, is this going to be the real successful model? I really do not know. As of now, it seems to be working. I'm grateful to God for that.
There is a question. How does a hospital which focuses on secondary and tertiary care keep its focus on primary and community services? And how do you keep a resident doctor wanting to learn skills from such hospitals, orient themselves constantly to public health mindset?
Yeah. One of the ways is to, you're asking the first part of the question, sir? Two questions were there.
Focusing on primary and secondary care, how do you continue its focus on primary and community health?
Yes. Yesterday also we were listening from the CMC model also, of course, in a very mega manner, how CMC has done that, where the best of tertiary care is also available, but the arguably best of primary and secondary care is also available at various ways of. Ours is probably not as big as a model, but we have not cut down on any of our primary care or secondary care initiatives. In fact, to strengthen that only, we had brought in the other specialities. So that is why I was mentioning in one of those slides that it was not replacing the primary and secondary care that we have, but strengthening that reinforcing that we have most of the people who have come here for this conference are from family medicine and medicine together. So that that coexistence is probably what sustains it. You had asked a second question also in that.
Question is about residents who come to learn skills. How do we orient them to public health?
Yeah. I was very interested yesterday when you were mentioning about how the socio-economic aspect in rounds, no? I still remember when we joined as junior doctors, that aspect was always brought into our discussions. Those days, we also used to have to write the drug charges ourselves. We had to calculate if you are giving ranitidine this many numbers, that drug charges, we had to calculate ourselves and then write, and the total bill also we had to. Our hospital follows a system where you do not have to pay anything before seeing the doctor. The registration charges also comes after seeing the doctor. You can directly, without any payment, you can first reach the doctor, then the doctor puts all the charges. With computerization, one big drawback that has happened was this charging ourselves has changed and gone into the computers. So many doctors are not aware how much the drugs that they are writing are costing the patients. Now with the EMR that we are going to introduce now, this responsibility of writing the drugs comes back again to the doctors, where they can easily identify the cost that is going to the patients. One. Second is, this is in the outpatient department, but in the inpatient also, this social round sort of thing is very important. Even if you are not able to do it separately, to incorporate that into your rounds discussions. It is not just organs and this disease that the patient is having, but the patient as a human, as a wholesome care, that has to be built into the rounds that we do. So some of the discussions that we may have during our rounds is not about medicine, but about the payment capacities and other things. So that is one of the ways in which we can bring in that sensitivity to such things.
So last question. What do you foresee as the role of a family physician in the future?
Yeah, I don't have to tell that the last 2 days we've been hearing that again and again. It is definitely in these circles, it is very well felt that there is a need for the family physician. There is no doubt about that. And even other physicians and other subspecialists also to learn from that model and to be family physicians themselves. But whether the policy makers will recognize that and bring it out in a big way in our country, that remains to be seen. Maybe there has to be a lot of infiltration into the policy-making bodies and boards where this can happen. That is not in my domain.
Thank you very much. We'd like to thank Dr. Cijoy Kuriakose for explaining to us the model of Christian Fellowship Hospital, Oddanchatram, and all that they have learned over the years.
We would like to specially thank our speaker, Dr. Cijoy, and we request Dr. Vijayanand to please felicitate Dr. Cijoy on behalf of the department. Thank you.